The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr. David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, a compliance crunch.
That's a serious challenge for so many large health organisations.
That's Dr. Mainak Majumdar, the Director of Intensive Care Services at the Mercy Hospital in Werribee, Victoria, and an adjunct senior lecturer at the University of Notre Dame. And I'm presenting him with a difficult scenario.
It's possible for people to actually get away for extended periods of time without doing mandatory competencies.
Today is a challenging scenario. In preparation for short notice accreditation, a medical administrator contacts the quality team to check that all is on track, but learns that they are concerned about the low hospital staff hand hygiene compliance rate. This is driven by very low compliance among several of the doctor groups. Unfortunately, this low compliance with hand hygiene seems to extend to other required training, such as emergency evacuation procedures, basic life support, bullying and harassment, and cultural awareness. When the administrator mentions their concerns to the chair of medical staff, they say it's a long-standing state of affairs. The doctor's attitude is that they are paid to undertake clinical work and do not have time for administrative requirements. We are fully trained specialists and meet all our college requirements, so find some of the hospital's requirements a nuisance, they say. I started by asking Mainak Majumdar what concerns are raised by this situation.
The reality is, when you look at the data from the quality team, one of the things that you also realize is that this hospital has a higher than expected rate of CLABSI, of Staph aureus bacteremia. They have recently been audited by the College of Surgeons for a higher than expected incidence of surgical site infection. So to me, the role of an administrator, the role of an organization is to provide the best possible environment for these highly skilled specialists to do the best job that they can. In my opinion, there's objective data showing that they are not doing their best work at my organization. Given this situation, what can we as an organization do for them? We can provide them opportunities where they can refresh themselves on simple maneuvers. So hand hygiene comes to mind. We've known from the times of Semmelweis that washing your hands is a good idea. It reduces surgical infection. Things like the 5 moments of hygiene are well validated and widely used across the world. There is no reason for us to not comply with these things. That actually extends out into the culture of the hospital. So really, in real life, as a doctor, I would be embarrassed if somebody collapsed on the street in front of me and I did not know the basics of basic life support. I'm not expecting everyone to be an expert intensivist resuscitator, but nevertheless, to not be able to do a basic doctor's ABCD, not rush into danger themselves, make sure that they've called for help and done a very basic ABCD assessment and start some CPR as needed in the actual cadence as required. That should be a very basic thing which all healthcare workers should be able to do. And it would be downright embarrassing if this same senior medical staff member was to find somebody collapsed on the street and couldn't do anything about it.
So you're saying quite clearly that there are positive benefits to all of these mandatory training programs, the hand hygiene program, bullying and harassment awareness program, cultural awareness and safety programs, basic life support, and yet compliance is low. Why is it that doctors struggle to exhibit compliance with processes like hand hygiene?
I think there's multiple factors that contribute to this. I think the chair of the SMS committee made a very valid point where they said that traditionally hospitals make these mandatory as competencies, but they then do not account for the amount of time that it takes to complete them. Doesn't actually roster the medical staff, especially senior medical staff. And there's never been traditionally a culture of rostering senior medical staff specifically for tasks like this. And that's perhaps something as an organization we need to look at and change. So to give you an example, if I go through the expected times that it would take my craft group, intensive care, to do all their mandatory competencies, including ALS training, at a guess, I would say somewhere between 4 and 5 sessions would have to be given over to this. I am not aware of any department that actually rosters their staff to have 4 or 5 sessions in a year just to do this work when our clinical and non-clinical requirements are pretty extensive. The other thing, and this may be peculiar to Victoria, is many senior medical staff are VMOs. They have fractional appointments. They work at more than one centre. And it is simply impractical for a specialist to do 4 or 5 sessions unpaid, equivalent at each organisation, in order to maintain these mandatory competencies. So they may well have a major fraction somewhere else, for example, where they've done all these. It's only recently that we've come around to the point of view that we can recognize the training at one organization in our own organization. But the fact remains, and I speak from experience here, the modules in different hospitals don't necessarily have identical content. A clear example of this is, for example, for emergency physicians, it's vital that they learn about occupational violence and what to do with the agitated patient, because they have an unfiltered entrance, and a lot of patients with significant mental health and drug and alcohol issues do present in extremis in their department. However, I'm not aware that multiple hospitals have identical modules. And this does then become an issue all around. So on the one hand, we have a non-standardized, essentially unpaid process, which is a significant time commitment from the medical staff involved, with a lot of other competing priorities, which are seen as their quote-unquote core job. And we also have a situation which actually allows someone, because they're working across multiple organizations, to get away with not doing the competencies in any one of them. So when there's a high onus on the work, it's not paid, and there's not a lot of consequence, are we surprised we're seeing this?
That's the stick side, is threatening consequences. There's the carrot side as well, though, trying to make medical staff aware that there are actually benefits in undertaking the mandatory training. So let's take hand hygiene in particular. It seems so removed from day-to-day clinical work at times. How can we convince medical staff that there is a benefit to hand hygiene?
Again, this is where traditionally hospitals and administrators have not communicated the information that would probably change and influence behaviors on the clinical floor. So hand hygiene is actually an excellent example. Let's take this hypothetical hospital's example. If I came back to them and said, you're being audited by the College of Surgeons for a high incidence of surgical site infection, and that was well disseminated to the consultant group, and they were made aware that they were, in fact, an outlier in terms of surgical site infection. I'm not aware of any responsible medical professional who would walk into the hospital with the explicit intent of providing a shoddy service to their patient. Everyone comes into work every day to do the best that they can. And if the information was disseminated to them correctly, explaining that in this hospital there is a very high risk of surgical site infections to their patients, I cannot think of anyone who would then put their hand up and say, it's not my problem, I'm going to do nothing about it. So first we need to disseminate the information to them in a form that they can understand. I still remember at a recent medical administrators meeting where somebody said, explaining a funnel plot to our specialist colleagues is a challenge. We don't necessarily have to demonstrate the statistical data as it appears to us and as we're trained to read it. We can explain it in very simple terms, and incidence data is something that pretty much any medical professional can understand. And when they look at their own data and with their benchmark, they're almost obliged to do something about it. And that is where we can talk about the various steps. And as part of the various steps, we remind them that the single most effective step is hand hygiene. And we recognize that there are many steps in the infection chain. But hand hygiene is a very simple, very effective one. And that is likely to gain a lot more engagement from, say, senior surgical staff. In turn, their engagement also role models for their juniors and for the non-medical staff in their units. And I think that actually makes a huge difference.
I think that's a really critical point, is that we need to turn the communication around from this is something that the chief executive wants you to do, or this is something that we need to do to get compliance with accreditation, to something that says we have a high infection rate and hand hygiene is a critical step in the causation of those infections. So turning the rationale for undertaking the training around from being a compliance issue to being an improvement in patient care issue.
Correct. And I think that's the language that most bedside clinicians understand most, is when it is patient-centric. So if we keep, as you say, instead of saying this is your compliance data, if we bring it back to the patient metrics that they can understand and then offer them interventions, I don't know many reasonable people who would then turn around and say, actually, we're not going to do it and we will continue to provide a shoddy service. That I don't know many people who would actually stand up and do that. But I think traditionally the business of running the hospital and the act of providing clinical care, at least during my career, have largely been divorced from each other.
I'd like to explore the other side as well, that so much of the reported data is statistical data. It's the medical staff as a group, but you may have hundreds of doctors in your hospital, and getting a statistic allows each of the individuals to say, oh no, it's not me, I'm not the worst offender. How do we go about making that data individual and say, you specific surgeon or physician are not complying with hand hygiene?
Again, a carrot and stick approach is probably fair. In terms of the stick, I think in this day and age, every department undergoes hand hygiene audits. The data is published. We have a set compliance rate that is accepted by the board. That is the KPI, as it were, for all clinical staff to meet. And that is what people aspire towards. So that's the stick approach. I think more than individualizing, it's important to ensure that hand hygiene becomes part of your workflow. So once upon a time, and it's not that long ago that I was an intern, there would be a clinic with 4 rooms, but the sink would be outside and you'd have a continuous flow of patients, people would simply not have an opportunity, or it was very convenient in the flow of the moment to forget to get up and wash your hands. We need to look at how we remodel the hospital. We need to have access at all points. If there are the 5 moments of hygiene, then at all 5 points of hygiene, there must be immediate access to hand hygiene, whether it's alcohol hand rub or whether it's a sink or similar. And quite possibly options for both, where invasive procedures are being carried out. Thereafter, I think at a unit level, doing a unit level report does make a difference, and it is not very difficult to find out who the personnel are who are missing out. And that is where I think the onus can then be brought back to senior medical staff. It is their job to role model. It's not just for their patients. It is also they are the ones who set the standards. And that is where the accountability for individual clinicians, and that is where the accountability for unit heads lies. Ultimately, the standards that we walk past are the standards we accept. So if I, as a unit head, choose not to wash my hands, I may well have inadvertently forgotten, but then if I snap the head off the intern who said, "Sir, you haven't washed your hands," then what role model am I setting? We're all highly motivated, clever professionals. None of us will accept an approach which is do as I say but not do as I do. So it is on us to role model. It is on us to hold our colleagues accountable. And a lot of the times, like with everything else for patient safety, it is okay to say, "I'm sorry, I forgot," and stick your hands out and get somebody to spray the hand rub on your hand. That's not an issue. But I think somewhere there, we need to change the paradigm in our minds that I'm not doing this because somebody's making me, or in the famous words when I was a trainee, because the hand-washing Nazi is looking at me. That's not why I'm going to be motivated to do it. I'm going to be motivated to do it because of the person who's on the bed in front of me, who is relying on me to provide them the best care. And that is both the message and regular auditing and feedback in real time is what will eventually change the culture.
So we've talked about a couple of opportunities, getting the heads of department focused. What other communication mechanisms are there that you would put in place to improve medical staff compliance?
I think the first most important thing to improve compliance is really to have access. So if there is access everywhere, and modern day hospitals that we work in will have alcohol hand rub dispensers nearly everywhere. Since the pandemic, it's almost become de rigueur to walk into a shopping mall and wash our hands. So that, I think, as a population, our culture has changed.
So we've talked about a couple of opportunities to communicate the need to improve hand hygiene. If you were the Director of Medical Services and this issue came to you, what's the sort of communication plan that you would put in place? You clearly can't go out and talk to the hundreds of doctors individually. So how do you go about putting a communication plan in place to ensure that all the doctors are motivated to improve their performance?
The key thing is to involve, I think, a chain of communication, which ideally would go from, say, the Director of Medical Services to the unit heads, to the senior medical staff, through to the junior medical staff. And my personal view is that I would rather provide them with the data on the consequences of their actions, i.e. their line infection rate, their Staph aureus bacteremia rate, their line sepsis rates, their UTI rates, surgical site infection rates. So at the moment, for example, a lot of this data is collected, it's widely available, but I could take it upon myself to put it down on a unit-by-unit breakdown within my organization, give them the data, and not necessarily as complex graphs, and update them on a regular basis, say 6 monthly, and give them objective views of the improvement or lack thereof in the service they provide. ultimately, it is all about the patient. So if I provide them with patient-centric information, I suspect that would have a lot more impact. As an individual, I think the DMS going out and lecturing the interns in a public hospital is rarely an effective strategy. But again, speaking to the heads of units informally where some units are lagging behind others, picking those as a priority, asking them to role model, and then asking in turn the heads of units to disseminate this rather than coming from within the craft group rather than a medical administrator outside the craft group, I think sends a much more powerful message, identifying the champions and then giving them free rein to do their work and keeping them supplied with the patient-centric information that's relevant to them. And I think that's ultimately, it sounds controversial saying this, but I'm not interested in how many times somebody washed their hands. What I really want is for the patient not to get their surgical site infection. But that's the step A must happen before step B. But giving people the step B data, which is clinically more important to them, coming from within their craft group, and quite possibly holding it up against their peers across various organizations, that is likelier to get engagement. And in turn, when people are engaged, they will comply.
One of the real challenges is getting staff who observe poor compliance to speak up. How do you make sure the junior medical staff who see a consultant who's not washing their hands is empowered to say, "Sir, hang on, you didn't comply with hand hygiene"?
That actually has very little to do with hand hygiene compliance and more to do with medical culture generally.
Yes.
So I think over the years, we've had programs like Speaking Up for Safety, which my organization certainly subscribes to. I think, in fact, and I'm not spruiking for any one particular communication model. So in many of the organizations where I've worked in, there's a two-step process. One where instead of getting a junior person who may get dismissed to find an allocated champion within the department that they can speak to, who is now a peer of this person, and then having your peers come and tell you, "Hey, listen, we noticed you're not doing X, Y, Z," in a simple, informal, anonymous way, that sends a very powerful message. I think if the intern turned around and said you didn't wash your hands, and your colleague came around and said, "Hey, why are you not washing your hands? Our surgical infections are increasing. We all need to do this." I think the difference in response is pretty much guaranteed. And the second thing is to have a culture within the organization, and that is where moves like Speaking Up for Safety happen, where you've got graded escalation. And there's this lovely graph people draw about the amount of respect you need to pay and the seniority of the person and the criticality of the task. And the three of them need to triangulate. So if it's a critical task, then the graded assertion does not stop with them saying it once. The other thing is, it's very powerful when multiple colleagues are speaking up and supporting. And so if somebody speaks up and has their head bitten off for speaking up, to have the support of your peers and to know that you're doing the right thing makes a huge difference as well. So I think that is a culture change. Like all culture change, it won't be instantaneous. But I do believe that even in the last 10 years that I've worked in medicine, the culture has been improving. And I do feel that in my department, certainly I find my juniors are more likely to speak up and point out steps that have been missed. And they're actually quite active about looking out for each other. And in many ways, the way they seem to treat this is that they are keeping each other safe for the patient. And I guess the final voice is the patient themselves. I'm an intensivist, so a lot of my patients are sedated to varying degrees. But certainly in a ward setting, empowering patients to say, "Hey, doctor, you didn't wash your hands in front of me," is not a bad thing. Again, there's no culture of the patient ever speaking back to you and demanding that you do hand hygiene before you examine them. But perhaps there should be. Perhaps, as we do in the wards now, putting up education posters on what the patients can and should expect, what families when they come in to visit can and should expect. These are good things. Patients are the reason we exist. So engaging them and reminding them that all the care that they're receiving is for their benefit, and therefore they must speak up. If there is an opportunity for us to improve, we rely on them to speak up and remind us. I don't think that's a bad thing.
That was Dr. Mainak Majumdar, the Director of Intensive Care Services at the Mercy Hospital in Werribee, Victoria. And that brings us to the end of this episode of Safeguarding Healthcare. I'm Dr. David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.